Hello, everyone. I'm George Aleftiris, CEO of Sonic Insights Medical Corp., developers of Elokur, the first handheld 3D liver health assessment solution. Thank you for joining us for our first webinar in 2021, the role of next-generation non-invasive tests in NAFLD NASH. Today, fatty liver disease is an emerging health crisis that affects 1 in 3 Americans, and practitioners need simple, non-invasive tests to detect liver disease, to stage fibrosis and quantify steatosis. We're pleased to have Dr. Robert Gish share his knowledge on this important topic and share best practices for integrating NITs or non-invasive tests into your practice. There will be a Q&A session after Dr. Robert Gish's presentation, and we invite you to submit your questions via the Q&A feature on Zoom. Dr. Robert Gish is a fellow of the American Association for the Study of Liver Disease, the American Society of Transplantation, and American College of Physicians. He is a professor of medicine at Loma Linda University Medical School and UCSD Skaggs School of Pharmacy and Pharmaceutical Sciences. He is also a medical director with the Hepatitis B Foundation. Welcome, Dr. Gish.
Good morning. Thank you, George. I should say good day because I think we have participants from around the world and around the country. Relevant disclosures are posted on this slide. If you need more detail, you can go to my website. My website also has a very nice newsletter you can sign up for if you want more information in the fatty liver world and the rest of hepatology. I want to highlight that I just returned from Deer Valley in Utah from the 2-day NASH tag meeting, and I'd like you all to consider looking at that meeting. The information should be up on their website soon, and attending that meeting every year. It's really one of the best NASH meetings in existence, so I really want to encourage participation there. I just learned so much. I want to thank the organizers for that incredible meeting, and I'll try to share some of that knowledge as an overlay on the presentation today. I'd like to start out with a little bit of terminology, which includes the difference between liver enzymes and liver function tests. Sometimes we're in the habit of grouping all of these tests together, and it's very important when dialoguing with your colleagues, your patients, that you separate liver enzymes from liver function. This really reduces anxiety in the patients, and you're much more clear about that patient's liver health status. Bilirubin, direct bilirubin, is really the best liver function tests. Albumin and INR are also helpful. We do have an epidemic going on in this country besides the coronavirus, and that is an epidemic of obesity. We estimate that somewhere around 80 million people have fatty liver today, and obesity or being overweight is even a greater problem. A very substantial subset of these patients will have progressive liver disease. And it's our role, just like in hepatitis C or hepatitis B or alcohol, is to stage our patients at intake and during long-term follow-up. These non-invasive tests are very useful to look at stage and also to grade inflammation. Now, there's nothing perfectly accurate, and if you look in the guidelines, they still put the liver biopsy as the gold standard for making the diagnosis. But you and I know a liver biopsy in the real world for fatty liver patients is probably maybe 1 or 2%. I personally order maybe 1 or 2 liver biopsies per year in a patient with NASH, and it's usually when I suspect autoimmune liver disease or something else that's confusing about their clinical presentation, and I really need tissue. Non-invasive tests are now in the community the standard of care, even though the FDA requires biopsy for medicines to be FDA approved. Now we have this parallel epidemic we just mentioned, the COVID-19, and patients with chronic liver disease, especially cirrhosis, and especially liver cancer, are at much higher risk of morbidity and mortality from this infection. So it's important to know staging of liver disease, the presence of liver disease in patients with a coronavirus infection. Let's run through the agenda. We'll be talking about non-invasive test use and thinking in real life. I'll be focusing today on fatty liver, and I actually call this disease now MAFLD, M-A-F-L-D. I think that is the best test, the best term. And when we think about this metabolic associated steatohepatitis metabolic liver disease, NAFLD, it's very important to think about terminology and what we're communicating to our patients. Many of our patients with fatty liver are drinking alcohol, but we tell them they have non-alcoholic liver disease and we move quickly by that alcohol diagnosis. I think we really need to focus on metabolic components, and if there's an alcohol use disorder, our patients with fatty liver should not be drinking alcohol, and I think that's important to communicate. Fibrosis allows you to determine when a patient needs an upper endoscopy, when they need to start surveillance for liver cancer, and really important, we're going to have a lot of new medications coming out, and when's the right time to be doing interventions. Fatty liver, of course, is very important just as a baseline disease. There's a whole controversy, discussion about whether you do simultaneous non-invasive testing or sequential use. I'll tell you what I do in my federal clinic in San Diego in a few moments, but we'll talk through this controversy with some details. So, NAFLD, metabolic associated fatty liver disease. Be ready to embrace this new terminology. There's a lot of discussions and editorials and guidelines and guidances that are coming about this new term. Alcohol use disorder, AUD, is very important to be assessing in all of your fatty liver patients, looking for alcohol-associated liver disease or an overlap or combination of this alcohol and metabolic associated fatty liver disease. And know these terms. This is very, very important. There's a changing scenario, but the change has a lot to do with education. The amount of patients with cryptogenic liver disease is now very rare. I might see one a year that a patient, I can't explain the cause of their active liver disease or their cirrhosis. Another term that's very important to understand and use is this lipotoxicity. I have a patient I'll be seeing this week who I've known for 20 years who has what looks like an inflammatory syndrome, BMI of 38, sleep disorder, all sorts of somatic complaints, cognitive changes. And I really think he has a lipotoxicity syndrome, and that's what I'll be working on with him, is really to have another motivational level to get his body mass index down to 24, and of course to be alcohol-free. NAFLD or NAFLD clinical presentation is often sold as asymptomatic. I don't believe this. We labeled our hepatitis C patients as asymptomatic until we learned that hepatitis C was really a multi-organ disease, including a major impact on cognitive function. I think NAFLD has that same presentation. These patients often have sleep disorders. We don't order sleep workups very often, but I think if that was easily accessible, that would be part of my workup on every patient, just as I would be doing a panel of non-invasive testing, including imaging. The patients may present with elevated liver tests, a bright liver on ultrasound or CT or MR imaging. Measuring that liver span on your physical exam is very important, especially as we emerge from our wonderful world of telemedicine over the last year. Patients were coming in with elevated liver tests on statins. Statins got a bad label for about 2 decades, but now we know that statins are actually liver protective and part of managing hyperlipidemia, and now even as part of managing cirrhosis. Laboratory review, insurance, annual physicals, or other intake points. What are pragmatic steps when you suspect NAFLD? Of course, you're gonna look for diabetes, hemoglobin A1C, body mass index. I do a waist circumference on all of my patients, especially in those patients who we think have lean NAFLD. I look at AST and ALT, these liver enzymes, and I have a threshold alert. If the AST is over 20, the AST is over 30, I have a major alert to start doing a workup. Take a detailed alcohol history, look at those liver biochemistries, and of course, work up for hepatitis B, C, iron, medication use, alcohol we just talked about, very important. Second level would be an autoimmune workup, although in fatty liver, up to 70% of patients have autoantibodies at low to moderate titers. If they have normal immune globulins, the titer of autoantibodies are low, it's probably due to the NAFLD. And of course, liver ultrasound. We're going to be doing this attenuation calculation for fat and elastography for stiffness. We're going to now go into a little bit more detail on these non-invasive testings, which should be part of your daily management of all of your liver patients. And we really want to figure out who is F2, F3, who has cirrhosis, importantly, and who has very low fibrosis score, because in those patients, we're going to focus mostly on identifying people at risk for cancer and heart disease, because heart disease is number one, cancer is number two in patients with this lipotoxicity, this NAFLD syndrome. There's a great paper this week, sad paper, that came out identifying a variety of cancers that are found in patients with fatty liver disease. And this is very important. Be educating your patients as another motivation to attain that ideal body mass index. So fibrosis stage helps predict these fatty liver outcomes. 20-year outcomes, patients with 646 biopsy-proven fatty liver disease with these various hazard ratios of moving on from moderate to advanced to cirrhosis. And of course, we talked about liver cancer surveillance, upper endoscopy, looking for liver function with MELD score, CPT score, liver failure and death are educational programs. So how I educate or communicate with my patients is in a positive mode. How long do you want to live? What quality of life do you want to have? We can extend your life by X number of years by losing weight, by managing your diabetes, by managing your lipid disorder. These are very important positive messaging to be giving to your patients. Quality of life, length of life, these are great motivators for patients to adjust their behavior and consider therapeutic interventions. So here we have this nice pyramid determining high-risk features. Age is part of it because when you're older, you've had disease longer. How well or how poorly is the diabetes controlled? Hypertension is part of this metabolic associated liver disease panel. And of course, we have these cut points for the stiffness on transient elastography with KPAs. I mentioned AST. 20, I'm getting concerned. Over 30, very concerned. Over 40, very, very concerned. And I'll be doing this NFS and FIB4 scores. And in my clinic in San Diego, the federal clinic, La Maestra, we do actually 7 tests simultaneously on intake. Yanis Zapata is my nurse that works with me and does all these calculations. And when we start discussing a patient, I've got a worksheet in front of me that has this simultaneous assessment. And I'll talk about that a little bit more. Then in the real world, as a primary care provider, you may be doing an intake off an AST or off an ultrasound, and then moving stepwise through adding additional tests to your staging. And that's acceptable as well. Liver enzymes are a flag, but are inadequate alone in assessing NAFLD. This is very important because what is normal? What is healthy? Fortunately, we've had this reset. The first AASLD came out with women threshold of healthy at 20. They moved it up to 25. Men were at 30, now we're at 35. But this is a major reset from what was promoted by the different regional, local, national laboratory tests. But AST in somebody who's got an abnormal ultrasound or metabolic syndrome over 20 should lead to initiating a further sequential non-invasive test assessment. This just shows you ALT values may flag the presence of NAFLD, but there's a poor correlation of ALT with fibrosis stage, or actually histology. So it's a test to say do more, but it's not a test as a standalone. But what you can do is look at the AST to ALT ratio. The AST is greater than 0.8 of the ALT, you're concerned. AST equals ALT, you're thinking F3. AST greater than ALT, you're thinking F4. That's a free test. It's very easy to do on that initial intake. And it's going to be a test that you're going to integrate into your full assessment. Here's AST in fibrosis stage. You can just move down to the green box, the fourth and third from the bottom on this, and say, yes, in general, you get this trend with your NASH stage. As that number goes up, you have higher AST levels, but more importantly is this AST to ALT ratio moving from 0.7 to 1.2. So as you do your non-invasive assessment, look at that AST to ALT ratio. And of course, if someone's got an alcohol use disorder, you would be thinking that the alcohol may be driving that AST to ALT if your KPA value is low. And my favorite test to do in that setting is to do a PEth, this phosphatidylethanol level, which is available through all the reference labs now. The PEth test is the hemoglobin A1C of alcohol use, alcohol exposure, and it looks back about 6 weeks. My only alert on the PEth test is if somebody's really obsessive compulsive about using these hand sanitizers, you can actually get a false positive PEth test because they're absorbing a lot of alcohol, ethanol through their skin. So that's a minor warning, but just something to be thinking about. So AST alone lacks sufficient positive predictive value to adequately predict, but it's a flag to continue to expand your non-invasive testing panel. All right, we're ready for a poll. Are you performing a liver biopsy in your patients with NASH? And if it's more than 5%, you should answer yes to this one. A third are still performing liver biopsy. So I'm sure part of this is clinical. And I suspect that some of our attendees are doing clinical trials. And of course, the clinical trials for phase 2B and phase 3 either require, I would say phase 3 require, phase 2B, or it's very, very typical. Okay, thank you for your response. That's very, very useful. There's a lot of liver biopsies still going on. And let's see if we can go forward. There we go. So liver biopsy recommendation, basically as we described, clinical trials, you're not sure. Maybe you don't have any imaging tests for staging KPA stiffness or doing this attenuation calculation for fat. You really need more information. Your non-invasive tests are indeterminate. You suspect autoimmune disease, but there's cost, it's invasive, and there's risk of complications. I have this rule of fours just to make things simple. I haven't mentioned the platelet count yet, but if I have the platelet count under 170, I'm strongly suspicious for F3. Platelet count under 100,000, strongly suspicious for F4. One of the places where I've been working is in Fresno with a cancer center. And in the community of Fresno, many patients get into the diagnosis of liver disease after a bone marrow biopsy for thrombocytopenia. I think a low platelet count should trigger a full liver workup and then decide if you need a hematology consult. I'm going to say 95% of low platelet counts need to see a hepatologist or a liver specialist, and 5% probably should go on to see a hematology. Of course, I do the NAFLD, NAS score. These are online calculators, including APRI and FIB4. They're very, very easily accessible. They're free. And when you do these 4 or 5 tests simultaneously and then combine it with imaging, suddenly you're up to 6 or 7 tests to really be able to narrow down and keep that indeterminate zone less. So what are some non-invasive serum tests? Everybody's familiar with FIB4 and APRI, I'm sure. The NFS score is on here, which includes diabetes and albumin, interestingly. FiberSure and FibroTest have been around forever, but I've not used those 2 tests in quite a period of time. I felt that they always overestimated the level of fibrosis, although that was very useful in the hepatitis C days when we were trying to get treatment. LiverFast is the new test on the block that's now cleared for use, and it's available throughout the United States, and it's reimbursed. There's a code for that test also. There's 10 components, but there's really 7 blood components, and they have a proprietary algorithm to pull in these 7 blood tests and put it into the 10 component calculation that's on demand. There'll be more information emerging about LiverFast very shortly, so keep your eyes open for educational webinars. ELF test, developed by Siemens, is supposedly available in the US, although I have not found a way to order that test. It has 3 components that are very, very focused on collagen synthesis, breakdown, and turnover. So keep an eye on these and decide what you want to use in your practice. Now, FIB4 also has a challenge that once the patient's over 75, I believe it overestimates the fibrosis level. So you have to be a little cautious, a little knowledgeable about the components. All right. What is the first non-invasive test that you do in your patients? Where do your eyes go? Where do your fingers go to an online calculator? Are you ordering imaging as your first test, such as elastography? Love to hear your responses on this one. So AST to ALT ratio in half of our participants. That is great. Now, I think we have over 140 people, and we're only getting responses from about 15 or 20. So we have a few more polls to come. We'd love you all to engage with us here. So elastographies first, and 1 out of 5. Very few people are looking at the platelet count first. That's interesting, because that's really super simple to look at when I'm just scanning the labs before I start plugging things into a calculator. And few people are using the NAFLD score. Okay, very interesting. APRI's not even on the radar in this group. Thank you. Let's talk a little bit more. So image-based methods are becoming more and more available. And of course, ultrasound's the first one, but ultrasound usually doesn't tell you too much. But I want to emphasize on ultrasound, you should always be getting spleen size and portal vein diameter. It takes the radiologist just a few seconds, and it's the 12-12 rule. Spleen over 12 centimeters, portal vein over 12 millimeters. It's extremely likely that patient has portal hypertension and needs an upper endoscopy. Now, transient elastography is the most widely used staging tool at this time. We also have shear wave and RFE. These are available through different machines, including Siemens and Philips ultrasound. MR elastography is available in some locations. In San Diego, the clinic I have here works closely with Sharp. Sharp just got their MRE, and there's an MRE alone that's just in a few $100 range, and it's accurate in the right hands, because you can see in that lower left box here at MRE, it looks like this might be in the New York Museum of Modern Art with some type of Rorschach drawing. So it really does take a skilled, in my opinion, radiologist to give you that MRE result with data processing. Transient elastography, FibroScan's technologies in the upper left corner, and FibroScan's coming out with some new advances with their machines, with probes and real-time imaging as well. This will give you your CAP score and your stiffness. Up in the upper right-hand corner with shear wave and RFE, you can get a very nice two-dimensional assessments on where you're going to be calculating your stiffness, but there's less data here, a little less standardized. We'll be talking about our S-Wave technology, which has a volumetric elastography and also measures attenuation. Very short acquisition time, you get 5 to 10 image volumes, and this allows basically for a larger measurement of liver volume to give you more data. When we're looking at a liver biopsy, it's 1/50,000th of the liver. When we're doing MR calculations, it might be 10 or 20% of that liver. But it gives you very nicely a fibrosis, a liver stiffness calculation, and it calculates the level of steatosis. And we really have to have these two components to talk to our patients about their liver condition, their liver health. Here's a little bit more detail on transient elastography, shear wave, RFE, MRE, and our S-Wave, which includes this mechanical steady state, large volume, 100 cubic centimeters, and can go down to 15 centimeters. There is some limit with transient elastography, the way the physics of that sound wave projection and return takes place. So I think a 3D ultrasound is a good way to think about this new S-Wave technology. Transient elastography is in a specialist clinic, but it's very easy for a technician or a medical assistant who's trained. Shear wave, RFE, and MRE requires radiology facilities. And S-Wave also much simpler in terms of acquisition, skill, technique, technology. All right, next poll. What imaging tests are you using in your practice? So this really has to do with liver stiffness technology imaging here. We have transient elastography or FibroScan. We have shear wave, RFE, which is supersonic, Siemens, Philips, GE, and then MRE. If you could give us your primary tool that you would use at your facility, or if it's none. Thank you. Almost 80% are using FibroScan. 10% none. Oh, that's amazing. So we've got some gaps here, but we have a lot of engagement. Few people are using these secondary systems, and MRE at almost 20%. That is fantastic information. Thank you so much. All right, as we move through this, I'm going to pick up the pace a little bit. These slides in this presentation will be available online, so I'll be hitting some just top line information on some of these slides. MRE continues to be advertised, and I think the data is supported that it's better than ARFI in detection of fibrosis in this NAFLD population. This is a prospective study. And this is MRE better than transient elastography for the diagnosis of fibrosis stage. Now, it's statistically significant at 2 levels, either very early or stage 4 disease. That's where you want to know the difference. But we really want to know where people are at 2 and 3. Are they 0, 1, or are they 2, 3? Cirrhosis is relatively easy to figure out. And it's that 2, 3 is where we're going to be doing a lot of our interventions as new medications emerge. This is S-wave data, which is much closer to MRE than transient elastography through this comparison, giving support that this new technology is going to give you a highly accurate result, because I don't think MRE is really going to be part of our armamentarium in most places, either in the country or around the world, even though the technology is great. So some non-invasive tests for staging liver steatosis. You have MRI-PDFF, which is the gold standard. It's often part of clinical trials and FDA approval, drug development, moving from phase 1B, 2A onto 2B. But CAP is controlled attenuation parameter as part of FibroScan. It's now built in. And of course, if you combine that with AST as part of their FAST calculation, which adds another layer of information. And then we have ACE, this attenuation measurement available on the S-wave machine also. So anybody coming out with new imaging devices really needs to have this attenuation built into their device. And I haven't seen much on the Siemens, Supersonic, GE, or Philips about this. So I think that's one of the reasons a little less use. Liver biopsy and a non-invasive imaging, there are problems. And there are problems with biopsy correlating with biopsy. That was a big focus at NASH-TAG, is the more pathologists you add in, the worse the correlation becomes. So they're really talking a lot at the NASH-TAG meeting about artificial intelligence and machine learning to add to what the pathologist does. The pathologist, Dr. Kleiner, was saying he's very worried about being replaced by a computer, but I think everybody reassured him that's not going to happen. But artificial intelligence, machine learning may refine what we do with biopsy information. I think that's encouraging. This S-wave data, having a higher correlation with MRI-PDFF, is also very useful information. In other words, you can really trust this calculation as you receive that information as your data output on this machine. So non-invasive tests, we talked about imaging, elastography, age, gender, labs, all this needs to go into your calculation. And we've had a problem in the past with these large indeterminate zones. I've seen indeterminate calculations from 15 to 40%. And the indeterminate problem is even more indeterminate when you're just trying to figure out who is F2 and F3. So the question is, do you do one test at a time? Do you do 2 simultaneous, or maybe like in my clinic, I'm doing 7 simultaneous tests and then calculate my best estimate for their fibrosis and also thinking about their inflammatory score. So we really want to enrich our studies for this NASH F2, F3 calculations, put imaging well into that assessment. And in the real world, we're going to have imaging at many of our locations, which will be helpful. But if you don't have imaging and you don't think you'll have imaging in the near term, you really need to be thinking about these blood tests. And I'd ask you to track the information on liver fast as we get more and more information on that approved test, which is now clinically available. And on this slide, it talks about spleen size and portal vein, that 12-12 rule. I really want to encourage you to ask your radiologist to provide that information on MR, CT, and ultrasound. It's very easy for them to measure just a few seconds of work. Another poll. I want to find out if this 12-12 rule is part of clinical practice. So you can do spleen, portal vein, neither or both. Spleen in 40, both in 40, okay. Portal vein alone and none, which is fine. So 20%, I would say we have 1 in 5 of our group. Maybe after today, you'll be working with your radiologist, add that another piece of information, and be thinking about that as either your sequential or simultaneous assessment of fibrosis stage. I think this is very cheap, very useful. And if someone's got a spleen of 20 centimeters, they need to see a hematologist or something else going on in that patient in most cases. Great, thank you. All right, a little bit more information. This just talks about liver stiffness and the liver biopsy. In our minds, even though we're not doing biopsies that often, we're always thinking about these fibrosis scores. And of course, with like biopsies, in some cases, we want to get this pattern, like you can see in the F1, F2. This looks more like chicken wire fibrosis that you might see with fatty liver or alcohol, less frequently with hepatitis C or hepatitis B. And transient elastography is really great for negative predictive values. So when you get a very low KPA value, it's going to be, I think you're going to feel very, very confident that they're not at risk for liver cancer and that they don't need an upper endoscopy. It's once you get up in these higher F scores where we need further refinement. Now, I'm going to switch just for a second. This is in chronic hepatitis B because, well, we're talking about NAFLD today predominantly. But really, in all your liver patients, you're going to be doing staging. And this is really good information on transient elastography in this hepatitis B population. There's even more information on TE and hepatitis C patients. And as these new technologies come out, we're going to encourage companies who have these technologies, including RFI, ShearWave, and now S-Wave, is to collect data across all these different disease states. Here's a little bit more on this FAST test, which is now a data output as part of the FibroScan technology. And this helps advance you further in detecting NASH and advanced fibrosis. But you can have disparate results. Now, you can see in this patient, the CAP score is very low, so there's no fat in the liver. And the AST is sky high at 213. So this is a little bit incongruous, so you definitely need to take a look at the components and don't just look at the FAST score to make your determination. In this patient, I'm probably going to be looking at other factors, other imaging, other non-invasive tests to determine where I'm going with this patient. But the KPA value may be correct, and I'm going to say, boy, that high AST could be from autoimmune, maybe it's alcohol, maybe something else. And if the ALT is nearly normal, I'll be doing a muscle workup and looking for myositis or a myopathy. A little bit more on FAST score calculation. A lot of data that came out. There's a beautiful manuscript on this calculation. I'm not going to go into all the details here, but let's just say the data was robust and reliable. And the AROC here is 0.8 here. And then the pooled external patient cohort accuracy, AROC 0.85. So it's very, very good test, good quality test. And this is the FAST score performance versus FIB4 or NFS. There's a derivation on the left, external validation on the right. FAST score looking quite good here comparing to FIB4 or NFS, especially in a moderate prevalence population. Non-invasive accuracy, this is from the Regenerate study, and my point here is transient elastography and ELF, which maybe we'll have someday everywhere, but I'm still not sure about ELF testing of the blood test. But here again, data on high negative predictive value. Regenerate study, as you recall, is the obeticholic acid study that is still sitting in negotiation with the FDA about timing of getting that FDA approved for us to use. It would be first in class FDA approval for NASH patients. A little bit more on NIT accuracy. This has to do with indeterminate findings. So you can see from elastography, it's pretty narrow and APRI for indeterminate. ELF testing is interesting because the indeterminate was about 60%. So we have to really refine how we use ELF if we can engage that in our practice. So if you could use only one additional non-invasive test after simple blood tests, elastography is a good addition, TE, with a high negative predictive value. These new technologies that we talked about are some that are available, such as ShearWave, and RFI could be additional. And S-Wave, which is part of this VeloCure machine, is being assessed as a comprehensive solution for measuring fibrosis and steatosis. I've shown you some good data on looking at this in comparison to MRE and MR-PDFF. So simultaneous NIT accuracy, well, in my practice, I do 7 simultaneous tests. I'm going to figure that that high negative predictive value is going to be useful for ruling out cirrhosis. I've had this assessment in the clinic here in San Diego recently, like where would I use a blood test? Because I have transient elastography, FibroScan in that clinic, but I'm still finding about 20% of patients I'm confused after combining all these tests, and maybe I'm doing too many tests, but I don't think so. So an additional test such as a blood test may be useful when I have elastography in up to 20% of my patients. So I'm still thinking about how to put a blood test into this algorithm. So key lessons: simultaneous NIT utility, have a very high negative predictive value and an acceptable positive predictive value. There's still indeterminate findings in some patients. What about sequential NITs? This is what people typically do in their practice. This could reduce the number of patients in that indeterminate zone by doing one and then a second test. Although I'm thinking most people here are probably doing 2 or 3 simultaneous tests at that same time. Specificity is good. So here you have few false positive tests. So I think that's very, very useful information also. This gives you some information on ELF in combination. This really takes your indeterminate findings way down. So this may be a useful place for ELF. And here is NFS plus transient elastography. Now, I'm not getting this small of indeterminate findings in my clinic. It's ranging from really 8 to 20% in my patients. But as long as I'm staying under 20%, I'm going to be very, very happy. This is MRE versus transient elastography and analysis of fibrosis and NAFLD. MRE looks better than TE, but MRE, difficult to get, although it's not too expensive now that they've got a price for MRE alone. Key lessons learned here: sequential is good. I think simultaneous is better, but you're going to keep your indeterminate findings low, I think under 20%. So accurate non-invasive tests are strongly needed to identify patients with advanced fibrosis. AST and ALT absolute levels are not sensitive alone, but are triggers to do further workup. And we have a variety of tests, free calculators online, imaging, now commercial blood tests that are reimbursed by insurance company, including LiverFast. We'll know more about ELF. I'm encouraging simultaneous testing, I'll call it the up to 7 rule. And these tests are all useful. You have to be cautious about the use of one. And if you've got 7 tests and 2 don't match, but 5 do, I would say believe the 5. Thank you so much. I think we're on time now and have some moments for Q&A. Thank you so much for having me here. And I'd like you to embrace the non-invasive world.
Thank you, Dr. Gish, for that informative presentation. Simple, non-invasive tests to detect liver disease is a must, and we're pleased to be part of the solution to address the growing crisis of fatty liver disease. We'll now take questions from the audience. First question is, can you foresee elastography becoming a first-line assessment tool with a generic blood test such as FIB4?
Yes, and I think in hepatology and GI practices, elastography is going to have a very high penetration and will be, I'll call it like the French do, a vital sign for liver health and help you as a provider. GI, hepatology, our providers, our NPs, our PAs, pharmacists are getting involved in managing fatty liver as well. I think that's going to be crucial. And if you don't have imaging available and you're not planning to get imaging, I think you could add one of these blood tests that we discussed into your formula. LiverFast is available. FibroSure Fiber Test is available, but be cautious, and ELF may be in the near future.
Great, thank you. Now, another question. What do you think of CT1, which is being currently adopted to assess for NASH assessment. And once it's being reimbursed by Medicare, do you expect, what are your thoughts towards that use of test?
I think this is a very good question. I think we need to have a little bit more information and training on this CT1, but it's built into many of the clinical trials for developing NASH drugs and measuring NASH response. So this is a T1 calculation off the MR machine, which is inexpensive and may just come as a data output from that. So that's a great question. Reimbursement will help, of course, but we'll need more training.
Mm-hmm. Great. And another question from the field, how do you foresee the use of liver biopsy changing with emerging NITs or non-invasive tests?
My opinion is liver biopsies will drop to under 5% in general practice. We saw a higher number of that today in the polls. And in clinical trials, there's a big push to replace liver biopsy in drug development also. Patients don't like them, they're expensive, they're risky, they're painful, even though it's very rare that there's a fatal event from a liver biopsy. So liver biopsies are going to be on the decline. And, 1/50,000th of the liver does not represent liver health, in my opinion. But we've got great pathologists, and it will still be part of our tools.
And in terms of how do you envision NIT or NITs algorithm evolving over the next 2-3 years?
I think that people will become more and more familiar with all the NITs. There's so much training going on in these non-invasive testing, research, webinars, tools, that we're going to get better and better over the next 2 to 3 years and decide which ones we want to use predominantly. We might end up using just 2 or 3 and use the other tests as secondary tests, but we're going to get better. We've got some blood tests that are definitely into the mix now. We're using algorithms, artificial intelligence to help interpret these tests as well. We have put together a neural network where you put in these 7 tests I've proposed, and a computer through machine learning may come and give you a very accurate result.
Mm-hmm. And one more question, what are some of the features that you want to see in an optimal non-invasive test?
It's usual, reproducible, simple, inexpensive, accurate, but we're going to be using combinations. So I know there's not going to be a single non-invasive test that's going to answer all of our needs. We really need to learn how to use these in combination.
Okay. And one question that came from the field as well was, what is the payer response in terms of requiring biopsy or perhaps other tests as before undergoing intervention, specifically for drug?
That is a fantastic question. And the OCA world is very interesting because obeticholic acid met a major endpoint that was agreed upon with the FDA. But obeticholic acid has some safety signals associated with it that we've learned from really the PBC population, not in NASH at this time. But I think the FDA is risk adverse, and I think that staging will be important. Managing patients correctly will be important with this combination of information. I think when the new drugs come out, they're going to be focused on F2 and F3 patients. They're not going to be going into cirrhosis. So we need to be very comfortable with our cirrhosis diagnosis or ruling out cirrhosis. Hopefully that answers your question. There's not a real simple answer there.
And just further that question, what are your thoughts about digital therapy or intervention tools, which are being used perhaps for other, like obesity or metabolic syndrome, or even specific digital therapies that are against fat liver disease? Thoughts?
What do you mean by digital therapy, George?
Cognitive behavior therapy in terms of supporting, reinforcement of positive behavior through reduction of, negative behaviors.
This is very important. Multidisciplinary team, nutrition intervention, health intervention. In San Diego, I use a weight loss contract, and we'll have data coming out about using a contract because that's used in other use disorders, including alcohol use disorders. So yes, behavioral therapy, cognitive therapy, positive counseling, these are very, very important techniques. And that's really how I built in this message to my patients. How long do you want to live? What quality of life do you want to have? We discuss cancer, heart disease, orthopedic problems, sleep, kidney, liver. We put this package together about improving their health and thinking about that health and that life extension through their behavior modification. So I'm trying to be that counselor today doing, therapy, motivational therapy.
Mm-hmm. So with having both options or more than two options, as you mentioned, both CBT or drug therapy, how do you foresee the landscape changing over the next 5 to 10 years as more solutions, be it intervention and also more diagnostic tools, becoming to the forefront?
It'll be all about combination. So it's combination imaging, non-invasive testing at intake, and then combination therapy to treat fatty liver, lipid disorder, focus, diabetes, focus, inflammation, add-on, antifibrotic, useful. I think these are all going to be very key items in managing NASH moving forward, including this cognitive behavioral therapy.
Mm-hmm. With that in mind, do you see that management will be very important, and as well as quantification or staging of disease and its responsiveness of patient or the efficacious nature of the intervention?
Yeah, really, that's a great question because we're going to be doing these non-invasive reassessments every 6 to 12 months in our patients. That's either going to help us redirect, add on, or switch therapies, or reinforce that their behavior change or the therapy we've applied has been effective. So sequential testing, not meaning sequential over a month, but sequential testing in follow-up over multiple years will be a critical part of your reassessment of each patient.
And I do have another question about the Waco blood tests, AFP, L3, and DCP. Have they proven to be unhelpful?
It's a wonderful question. This is related to liver cancer risk. These tests are FDA cleared for risk assessment, and I think they're phenomenally useful. I've been using them over the last decade. They're now combined into what's called a GALAD, G-A-L-A-D score, GALAD, and there'll be two very interesting papers coming out shortly from very large networks that will give us a lot more information on how to use these. They're a key part of my assessment of patients once they're at F3 with NASH and hepatitis C, and definitely all my cirrhosis patients get these 3 tests and calculate a GALAD score every 6 months. So liver cancer risk assessment.
I know recently the FDA had a update and guidance in terms of drug trials and endpoint measurements. Any thoughts towards that in conjunction with NITs and their role of measuring endpoint of success with drug trials?
I don't believe the FDA is going to change in their phase 3 studies from the liver biopsy requirement, but they'll continue to step up gathering information on non-invasive tests that we all can use in our general practice. This recent update, I think Frank Ania was the lead author on that update, was very interesting because I think, I don't know this as a fact, but I'm projecting that that letter came out as a refinement of the FDA details about how they're doing drug development and balancing risk and benefit. Because when the letter went to Intercept on OCA, discussing that the drug was not ready for approval yet with the current data, it was all about collecting more information and being able to balance risk and benefit. And to balance risk and benefit in a given patient, you need to know the stage of their liver disease, because if they're F0 to F1, a medication, even with a modest risk, you probably don't need to utilize. But F2 and F3, you're going to rebalance that risk benefit. And the information we get from the FDA And this is a long-term disease. You know, fatty liver is a 20 or 30-year disease. Coronavirus is a 3-week disease. So each disease state has to be looked at individually. Is it fast progressing? Is it slow progressing? And right now with our NASH patients, we do have a subset that are fast progressors. That was very interesting information that came out of the lead-in data on the Regenerate trial with OCA. We need to find those fast progressors, and again, using non-invasive tests. You can't do a liver biopsy every 6 months or even every 3 years. So non-invasive testing is critical for following your patients and finding out who is fast progressing until we have genomics. We're not ready to do genetic testing in our patients for PNPLA3 or SF6 or some of the other genetic mutations. It's not ready for prime time yet.
Mm-hmm. And what are your thoughts to the use of or measurement of steatosis in combination with fibrosis as a indicator of risk progression of disease in patients?
Yes, the more fat that a patient has in their liver does have a correlation with a higher risk of progression. So I do want to know that. And telling the patient how much fat in their liver and then following this attenuation with sequential imaging can help either redirect a patient or continue to motivate a patient. So fat calculation, very, very important.
Mm-hmm. And I guess with some of the new therapies, specifically for drug therapies or even the CBT digital therapies, as being one of the targets of mediation or reduction, I'm assuming that has an increasing important role for imaging as a tool to be used for assessment of patients.
In my ideal world, George, each patient would have some level of quantitative or semi-quantitative liver imaging. And I think these tests are becoming very widespread, much more prevalent, and I think are a key part of our management.
Mm-hmm. Mm-hmm. One question from the field as well about FiberSure and use as a NIT. Anything that commentary?
Right, I was making a point earlier that FiberSure and FibroTest, I believe, overestimate liver fibrosis status, liver activity. And that was very useful when we were trying to get hepatitis C drugs approved through insurance companies when the barriers were in place. But I haven't used FiberSure or FibroTest in the last 5 years. The data for the liver fast test from Fibrognostics looks very, very encouraging. And there's going to be more data collected on that as well to help add that to our armamentarium.
Great. I think that was, if not all the questions that we addressed from the audience. I'd like to thank everyone for the questions. And Dr. Gish, any remarks, any thoughts to the webinar or the content or even the questions that arose before I close?
Well, George, I learned a lot. One of the things I learned today is there's still a lot of people doing liver biopsies. I think that number will decline as those biopsy providers, biopsy-focused providers, learn more about non-invasive testing because the biopsy just samples such a small part of the liver. And one of the problems with liver biopsy is the radiologists do them and they love to use 18 gauge needles, which in my opinion are not worthless, but pretty terrible. If you're going to be getting liver biopsies, you need 2 passes, like the FDA guidance document in 2012, the ASLD guidance document in 2012, is that you should only be using 16 gauge needles, get 2 centimeters, get 20 portal areas to really assess a biopsy correctly. So if you're going to biopsy, do it right. Thank you.
Mm-hmm. No, it's great closing remarks on the use and utility of biopsy, and certainly while it has a role in clinical research, it has a less or diminishing role as part of practice, but it certainly has a continued role in general. But on that note, I'd like to bring the webinar to a close. Thank you for attending, and thank you, Dr. Robert Gish, for sharing your knowledge. We hope that everyone joins us for our next webinar in April, which will talk about S-Wave and Velicour, which is available in market today. So we hope to see you soon. Take care. Bye-bye.